Good afternoon. We have a small but privileged group here in front of us. I hope you all realize that you're now attending a session about patients' summaries, clinical codes, standards, and classifications. It's a rather challenging title, but vital to the development of patient-centered care. My name is Cathrine Mølstad, and I work at the Norwegian Nurses Organization, and I have the privilege of moderating this session. The first three speakers will talk about patient summaries, the development, meaningful use, and empowerment. The fourth speaker will present a Norwegian strategy for improved quality of care through the use of codes and classifications. Just a second. The first speaker is Cathrine Cronaki. I'm not sure if I say that correctly, and she's the Secretary General of the EHL International Foundation. Cathrine has led the Trillium Bridge project concerning the transatlantic exchange of patient summaries, and from 2017, Cathrine will lead the Trillium 2 to scale up the adoption of patient summaries. She is working on e-standards, aiming to develop a roadmap for collaborative standards development, and she is also on the board of European Federation of Medical Informatics, and member of the eHealth unit of European Society of Cardiology, and founding member of the HIMSS community of women in healthcare information technology. You're a very busy woman, obviously. And her title is, Can Patient Summaries Leverage HL7 FHIR to Unlock the Power of Data and Drive Digital Health Innovation? All right, thank you, Cathrine. The floor is yours.
Thank you, Kathy. Let me open this. Okay, can you hear me now? All right, so we have a question here, and I welcome your thoughts on it, as I will also laying out in front of you my thoughts, thinking about potential answers and actions that are related to this question. Can patient summaries leverage HL7 FHIR, which in my view reflects on innovation in standardization to unlock the power of data and drive digital health innovation? And in my speak today, I will address HL7 FHIR as a window to data. And it's a lens, however, and how you see the data and how useful you can make the data is work that remains to be done. So, central to my talk is also the change that's happening in healthcare today. And I'm citing here Eric Topol on the old medicine and the new medicine. The old medicine that has been one size fits all, and the new medicine that is individualized. The one-off, the fee-for-service model, the doctors as problem solvers, and the doctors as collaborators, members of a health team that involves also the patient. So I like the idea of the Gutenberg moment in healthcare, because sometimes I feel that going digital is actually changing everything as much as printing changed our society 600 years ago. So patients and patient organizations now are calling to play a different role of leading clinical trials, of leading innovation. Oh, I'm not changing slides. Okay. So yes, so I've spoken to this slide, and I've spoken to this slide, which is the Gutenberg moment for healthcare. Yeah, the printing that has changed the way that that healthcare will work, and the role of patients, finding your DNA yourself, and also advocacy groups that lead clinical trials. Yesterday, I was at the Parliament, and it was a commemoration of the World Pancreatic Cancer Day. And I was thinking, how far are standards today for interoperability, for communication of information from serving these patients? And it is true that these patients are really rare. They have very little time. They are underdiagnosed, and they face significant logistic, emotional, and other barriers to their own treatment. So can patient summaries help in this case, and how? I think this is a difficult problem, but it is a real problem. I think many of you have heard of a person that had pancreatic cancer and was amazed at how life can change by a phone call or by an email these days. And I was in this talk, and people were arguing about minimum standards of care throughout Europe. They were referring it to centers of excellence. They were referring to registries for improving care. And I was thinking, yes, but that's not enough. We need to do more. And I'm thinking, can patient summaries be the first steps in that direction? Help communicate this first step that will make things different, that will help us make sense of the digital, use digital technology to improve our lives, really? So we are in these standards, myself and Robert, and also Anne has been involved through EFMI with a vision to think of a globally health ecosystem and where people receive timely, safe, and informed care. And you have interoperability assets that drive co-creation, that drive a trusted dialogue between the market and the providers. And we can have and granted our great expectations. And our kind of results or expected results are very meager. We want to help e-health projects understand their goals. We want to help develop clinical content, and we would like to develop a roadmap, an actionable roadmap for collaborative standards development. And now the question is, where do patient summaries, remember that was the question, where do patient summaries fit in this ecosystem? And back in the Trillium Bridge project, we said this is social capital to have patient summaries for each one of us. And some key things that we can consider are problems, procedures, medication, implantable devices, vaccination, allergies, labs, images, and counters. Those are simple things. We can do them. But they are not point-to-point, so the market doesn't have a really easy way to monetize them. They are not organizationally dependent. So the question is, can we change our culture? And can HL7 FHIR play a role there in unlocking data, in unlocking databases that are back in national barriers, facilitate decision support, navigate the system? And I would say yes, but we need to change our lens, the way we see things. We need to understand, as Harvard Business Review mentioned like a few days ago, the power of platforms, the power of the sharing economy. And we have to think different. We have to think of how aggregating our power can change the way we administer automation, can change the way we deal with networked knowledge, and allow us to do better orchestration. One of the things that this article mentions, and I suggest that you read it if you can, it's quite fresh, was the fact that Athena Health, they are doing back office, computerization for organizations. They looked back 30 days to see how many appointments were there available. And they found that 94.5% of the appointments were actually booked. No, they look forward, excuse me. 94. And then they looked back. And they looked at how many of the appointments were actually executed. How many do you think were actually executed? Yes, thank you. You were, yes, thank you, Diane. Yes. I told that to my husband, and he said, no, absolutely not. He's a computer scientist. This is unbelievable. We have to look at the data. I cannot believe this. It's remarkable, right? This is so much waste, so much lost opportunity to tap these resources. How can we do that? How can we help triage on the spot? I could also cite from the same article, EHiN-FH, who ran a one-day pilot, 2,000 flu shots in 4 hours in 35 states in the US. What can we do in Europe? So, the 90s, I love this. I asked Ed Hammond. Yes, I asked Ed Hammond, who is an amazing guy, to tell me what a patient summary is. And he pulled this slide here from 1997. And he said the patient summary is current problems, current medication, action list, and allergies. And next is the RIM. So we have advanced technology. We are really digital now. How these translate? So they translate into disruption. And I'm going into the FHIR discussion to give you a little bit of how I feel FHIR fits into this question. Excuse me. So we were into something complex, and there is a big thing to do things just in time. Go simple. They were things that were costly, subscription-based. Now things are free. They were things that were specialized, needed high-paid consultancy knowledge. Now we want things that everybody can do. And we had things that were comprehensive, huge clinical models. We want to make them one bite at a time. Some people hear me say, take the RIM and build it point at a time. So what is FHIR? It is based on fast healthcare interoperability resources, small things that open small windows to see data. They have a specific identity and behavior. They have a lot of support on the internet, a lot of implementation. You can extend them. They're based on the 80-20 rule. We want 80% of the cases to be fulfilled. The rest, 20%, will be extension. We want them to use not specialized protocols, but protocols of the internet. And we want them to be based on composition and extension. Excuse me. One of the exciting things I've played around in just 1 hour, and I loved it, was clinicians on FHIR. And these slides are modified from David Hay, who has developed many of these ideas. So here, if you go online on this side, you will be amazed at how he combines, and in FHIR this is possible, data with profiles, conformance, and terminology. So you can develop your value sets immediately. So it's just amazing. And here you can see the different elements, and I'm sorry that the slides, I don't know how to show, but the different resource types are very small in font, but you can see allergies and intolerance, conditions, medications, observations, and so on. So everything is here. And it's not specific to healthcare. It's externalization. You can see also mind maps. You can view the data. And I'm afraid sometimes I think this is getting back to the RIM. But the most important thing is that even within a vendor that has to customize their implementations in each of the different sites, this approach, the FHIR approach, allowed them to create unique interfaces that focus on the user, so that the clinicians can have their own interface on the same data. So it's very much about appealing to the needs of people. So again, the question, going back to the question, is this enough for patient summaries? Is this enough to make the change, to drive change? And in the standards project, we came up with a number of gaps I will briefly mention here that need to be addressed in the medium and long term, and we have to find the roadmap for this. And those are: how do we embody professional guidelines? How do we make clinical information models that are accessible? How do we mix patient and provider generated data? How do we achieve regulatory clarity? How do we capitalize on terminology resources? How do we play with localization and adaptation in a sustainable and scalable way? How do we use open access and open data tools? How do we make sense of procurement? And how do we maintain and govern the process? So the idea comes again from IT. And I'm a computer scientist by nature or by training, by initial training. So I go back to IT. And looking at the bimodal model of Gardner, I think we have a solution. We have to leverage the fast-paced world that we are living with a slower process that digests it and create an infrastructure for interoperability. So, in conclusion, patient summaries can leverage FHIR to unlock the power of data and drive health innovation. But they're just a window to the data. And it takes a village to be able to make sense of the data, to deploy them, to achieve decision support, to change our culture of working with data, with dealing with the digital. Thank you very much for your attention.
You have a couple minutes. I wonder if there are any questions? Hard to see them, isn't it?
No questions?
No questions? Everything's completely clear. It's a difficult subject, but a lot of things have to be in place in order to achieve patient summaries. Okay, thank you.
All right.
You want to take your computer with you?
Computer, take off my...
Give it to... Robert, are you ready? Okay. So our next speaker is Robert A. Stegwee. Am I saying it correctly?
More or less.
Almost, almost. It's Dutch. He's the director consulting for healthcare technology with CGI. I tried to find out what CGI means, but I couldn't figure that out, but I'm sure you'll tell us. In the Netherlands, he's the chair of the European Standardization Committee in CEN TC 251 Health Informatics. He's a member of the board of HL7 Netherlands, an affiliate member of Health Level 7 International. His passion is Me Health, improving the healthcare experience from a healthcare consumer and professional perspective. He will speak about, can patients and informal caregivers use patient summaries and personal health records to navigate the health system? That's a very good question.
Thank you. And thank you for this introduction. Cathrine just talked to you about FHIR and how FHIR can make patient summaries come alive and help navigate the health system. My question will be not how, but why? Why would we do this? How would it help patients? How would it improve me health in general? Basically, we all know that healthcare doesn't happen at the hospital. At the hospital, you're there in an encounter, but whether you get better or whether you stay healthy depends very much on what you do in between. And there's questions about, do these checkups have to be regular or should they be more just-in-time based? So you have to really think of what's happening to your health is not happening at the hospital. It's happening somewhere else. And the health system has much more to offer than just your encounter with the doctor. So there's a lot of other things that will help you. For instance, patient groups, talking to others. If you're handicapped, if you have a spinal problem and you're stuck to a wheelchair, it will help a lot to talk to others about what's the best way to make sure that I'm mobile. How do I make sure that I'm comfortable sitting? What different types of cushions are there? I mean, that's not something that you will discuss with your doctor. It's something that comes from the patient groups. Well, I found this material more helpful than that. So trying to find those patient groups can sometimes be hard. Your own personal experience comes into play. What works best for me? And that can be termed in clinical terms through a patient summary in terms of allergies, but sometimes it's just how I feel. Do I feel comfortable going around in a wheelchair, or do I want to have a prosthesis and walk around with that? And it can be different for different people and how it works. So your personal experience in what's your quality of life is very subjective, and it's not something that will be measured by by your healthcare provider per se. There's other forms of help out there. Buddy care can help you enormously. Some of this already comes from the early ages of HIV/AIDS, when there were already bulletin boards. This is in the pre-internet world. Bulletin boards where patients would share their experiences. There would be buddies to help people along, get the right medication, etc. Of course, in the internet age, we now have Dr. Google. How many people look to Dr. Google to figure out what's going on with them? Or create better systems for self-management. People with diabetes already have quite an extensive form of self-management, but that can be improved and it can be extended to other diseases as well. And there will be innovative therapies that are more focused to your personal situation, your personal world. But how does that relate to this hospital-based or healthcare provider-based system of you come in once every so often, and is that person going to help you navigate this system? I think not. There's much more going on. So you have to have something to navigate that system, to figure out where to go. And like in a navigational system, we have a GPS, we have a global positioning system that tells me where I am and where the other things that I might need are. We need kind of a GPS for healthcare as well. But the GPS, the coordinates of your need in health and the possible routes and the places of interest around you in your health are not well defined in the way that it is defined with a global positioning system. So you really need to have an understanding of who am I, what's happening with me, and how does that relate to the services that are around me, and how can I discover those services and figure out whether they're right for me or not. So really, it begins with who am I in terms of health and the health system. So it starts with my health. What's happening in my health? What's going on? And that is based on electronic records. The providers will keep your electronic records. And in the Netherlands, we just passed a law on consumer rights on electronic patient records. And that says a lot about security and privacy, but it also says that you have a right to say who can get access to my records, but also that you as a person can get an electronic copy of your record. And that electronic copy would be the patient summary with structured encoded data. That's kind of your GPS coordinates of where am I in my health journey, in my health system. And it has to be meaningful. I mean, it doesn't make sense to actually get a copy of my patient record with every minute of O2 saturation when I was in surgery. I mean, that's not helpful. I mean, that was very, very helpful when I was in surgery, and it's very helpful for the anesthesiologists to look back and say, well, did something go wrong? Did we do our job? What happened? But it's not relevant for your positioning of your health in your in the health system. So it has to be a meaningful patient summary, and it has to be, like Cathrine said, it's a lens on everything that's known and picking out the bits and pieces that are relevant for you at that point in time. So that's the start. Where am I? Where do I want to go is the next question. And the next question comes in terms of making use of that information in a two-way street. So using that information that you have in your encounters with others. And augmenting it also with patient-generated data. I mean, I have an iPhone, it counts my steps, it knows my activities, I can use that data. There's a lot of more sensor devices that will provide information on what I've been doing, and that can be very personal in terms of whether it's relevant for you, whether it's relevant for your doctor. So you need to be able to share that data in a meaningful way also with your healthcare providers, so you can have sensible shared decision-making discussions. And it's about alternatives. It's about what are the expected outcomes, what's the risks involved, and how does that influence my decision in terms of what type of treatment would be right for me. And this, I cannot stress this enough because it's a very personal journey that you have to take. It really depends on what's your experience at that point in time. Do you want to live with pain? Do you want to live with a disability? Or what is it that you want? It also depends on your own lifestyle. Do you want to be active? Do you want to teach? Do you want to walk around? What is it that you want to do? And how does that fit with your health and the perspective on your health? So it's really about personal preferences, and personal preferences also come into play when we're talking about personalized and precision medicine. That's not only preferences, that's also your genetic makeup. It's also the way you respond to certain treatments and any history in your family that will provide better information about whether you can or what you can expect of certain treatments. So making it a two-way street. So first we have the electronic records, and then we use them in our decision making within the health system and trying to navigate the health system in that personal way. But it goes on like that in terms of what is it that we can do, because this is still provider-oriented, but in a general scheme of things, we're talking about personal health records. And personal health records have been around for quite some time, but it's very hard to figure out how to make them work. And I think FHIR, as Cathrine explained, provides an immense opportunity to easily tap into the data that you have in your personal health record. And your personal health, and it's no longer a record, it becomes an environment that helps you with treatment. It helps you with the exchange of data, the two-way street I just mentioned, and it also helps you in all kinds of lifestyle activities and trying to figure out what works for me and how can I stay healthy and feel good. So that's the My Health part of it. It's already there. I stole the picture from the NHS My Health. And you can expand it, and that has been piloted for a number of cases with Mijn Zorgnet, which is my care network, where you extend it, not just being your personal part, but use it to navigate in a network of people, your informal care providers, but also other patients within the same patient group, your friends. So you have different types of networks, open networks, closed networks, and buddy networks that you can open up alongside this and have different types of services come into play. For instance, if this would be about your father who's having problems with dementia, you can create a network and say, who's going to do this? I will do this, and have all kinds of activities in terms of preventing loneliness, supporting day-to-day activities, whatever, and make sure that that network of people is connected around your father or your mother or whomever you want to take care of. So coordinating that care and coordinating the activities and being informed about what's going on, not only to the informal care, but also towards the care professionals, that they know what has been going on, and you can report easily back from a personal point of view and from your informal care position. That also helps in creating a better informed network of people around you. Of course, this all means that you have to have ways of filtering that data. You have to have that lens of how do I find the data that's relevant for me at this point in time with this decision that I'm making, with this activity that is going on. And that means that it has to be structured data, because you have to be able to interpret what's going on. Nobody in his right mind will expect a doctor to read 25 pages of text in preparation of a 5-minute consultation. So you really have to figure out how to actually extract the relevant data and provide an opportunity to drill down into that data set. So that's where structured data comes into play. Because if you don't have structured data, you cannot navigate. You don't have your GPS. You don't have your coordinates of where I am and what's, in terms of where I am, what's relevant for me at this point in time. And that's really where we need to go. So in terms of having a personal health record, having a professional summary, it all links together. You have to start at the beginning. Where is my record? How does it relate to my position in healthcare? How can I use it in my discussions with my healthcare provider? And how can I use it to navigate the health system, to figure out where are other services, where are other patient groups, where are buddies, where are self-management services, where are services that I didn't even think of from either a formal health system point of view or from a more commercial added value lifestyle provider point of view. How do I find those? How can they help me improve my life or the life of my loved ones? So that's basically how I feel that patient summaries and personal health records can help us as patients and as informal care providers to navigate the health system and make the best from a personal perspective and from a personal experience perspective. And that's my message for today. I'm not sure if there's still time.
We have just a minute. I think this was very exciting, actually. Very nice.
Thank you.
Any questions out there? It's kind of hard to ask a question. It's a completely different perspective than the last. You think, oh, what we've been talking about the last 10 years, and now we're going to look instead of the medical record or the health record, but it's my information.
Definitely.
It's wonderful. Thank you very much.
You're welcome.
And they've all received their present already, so I haven't forgotten that. Okay, our next presenter can join us. I have the pleasure of introducing the next speaker. That's Moen, and I have known her for many years. We don't want to start counting Anna. She's a professor, she's a nurse at the University of Oslo and the immediate past president of the European Federation for Medical Informatics. She has been active in e-health since the 1990s. And she is one of the founding members of the Norwegian Nurses Organization's Special Interest Group on e-health. Her current research is on tools and apps as innovative services for homebound elders. She is member of the European Commission of e-health stakeholder group and leads the task force on citizen health data. And Moen is going to talk about digital health literacy and discuss challenges to tapping the potential of the patient summary to advance digital health literacy. And it's a long sentence.
Yeah.
And I didn't make it.
This is your language.
Yeah, barely. And assist engagement of patients and their families and with their health team. So Anne's title is Can Patient Summaries Advance Digital Health Literacy and Assist Collaboration of Patients and Their Families with the Care Team? Thank you.
Thank you. Apologize for the long title, and I promise to do better next time. My comments will relate to more of the slower processes. How do we make sense of the information? And there are different set of drivers that all points us in the direction of collaboration, because what this patient summary can do is to open access to the health system's information or the electronic health records information about me and what's has been my health history. There are a lot of variation in who the recipient is. There are many stakeholders. There are also many drivers. This morning we heard about the initiative starting, or that was sort of coined in a Norwegian white paper, One Citizen, One Record, from 2012, and all the activities that comes after that. But we also see internationally a shift that can be coined in a term like the patient will see you now that Cathrine alluded to, and also patients can help. From another point of view that's also driving into some of this, this discussion is the right to personal information in digital form. The Dutch colleagues have been active saying that, like Robert explained, that you can now get your electronic version of the your electronic health record. There are 3 important directives that will also, I believe, have some influence for us here in Norway. One on data portability, that you can request electronic copies of your health information, not just PDFs. That health data and cross-border healthcare is something that should be supported and information need to flow with. And then reuse of public health information. And of course, bringing to the table is the personal, the professional, and the population perspective, where we may see confusion because we cannot necessarily make sense of the information, and it might not be relevant for me right now, or it may not be accurate, or I don't want to deal with it. We can also see a lot of co-creation, collaborations, and contributions. And I would also like to bring to the table a discussion that we need to take on autonomy and accountability. Because there is a reason why the records are the way they are, and they serve a purpose of professional accountability. At the same time, liberating the data, making them available, can support my autonomy. As we move forward, I would like to share with you this slide that actually is a few years back. Smart patients. Smart patients comes in many shapes and being smart is multifaceted. You can present yourself as a self-assured, motivated, aware, resourceful, and talented person for yourself or for your loved ones. But at the same time, and this being smart is also balanced out by uncertainty. Being scared, you can have minors, you can be anxious, reluctant, and be perceived as time-consuming. What I think is, since my mentor, Paddy Brennan, coined this slide in 1998, and I would encourage you all to sometimes revisit some of the ideas and thoughts that are more than 10 years old, because some of the conceptual thinking still carry. But what is important, as we have had the most recent white papers, is that this is also affected by a digital divide, where we have a lot of discussions about innovation, and we really don't necessarily know what is an innovation and when it's an innovation. We have a lot of discussion on we must change, but to what and who set the premises? So there are a lot of unresolved questions when we think about the patient summary, when we think about liberating the information, making it accessible to us as citizens. Adoptions of these innovations, whether I think it's an innovation for me, or if it is someone else that thinks it's an innovation, comes with the speed of trust. Can we trust this new thing? Can we make sense of it? Does it help me? And in that equation, I will argue that we need to pay much more attention to e-health literate citizens. Meaning that we need to put some efforts into the slow processes, making sure that we are empowered to identify, appraise, and use the health information that we find, whether it's from the patient summary, or if it's supporting resources, or if it's all the resources that we access when we are not in the healthcare domain. And we need to think about relevance in my life trajectory. And in this picture, the patient summary is important, but I think Robert also gave us a nice insight to how additional resources and how patient-generated data can add to the picture. And most importantly, I would argue that we have to pay attention to and align to what makes sense. In the classic work of adoption of innovation, trialability is a key issue, meaning that we should be able to test and be able to, and we ought to think about how we can align some of the new suggestions with something that we already do. And some of the things that we do is that we, de facto, and you can just think about yourself, we are differentiating information according to perceived relevance, according to when we need it and usefulness. So a few years ago, I was part of a study where we looked at how people managed health information in the context of their home and what they do when they are not with us as healthcare providers. And we found that a lot of information and devices, artifacts that are in use for personal health management relates to, can be coined as just in time. It's information that's with me all the time. It can be information that's readily available, it's at hand. It can be information that I think it's important that I know where it is, but I don't need it immediately. And it can be information that's just because someone gave it to me. Taking these examples into the question of the patient summary can help us to decide on how to build the summary and what makes a patient summary understandable and fit for collaboration. And in this picture, digital health literacy comes in. Being able to find information and make sense of it, for short, is very important. So, what do we need? And I will also bring to you a version and a quest for a navigator. So, when we think about collaborative tools and think about some of the ideas that we are navigating according to where expertise and being an expert on yourself is the true north, we need to think about at least 4 dimensions. And I think these taps into some of the work that Cathrine is involved in on the European scene and some of the experiences and the interesting thoughts that Robert brings to this session. It has to do with the personal characteristics and my preferences for health and wellness. It has to do with my capacities in terms of digital literacy. It has to do with my healthcare experiences, expectations, and my needs. And it has to do with how I, and then of course it's the royal we, how I and my family members or the people that I choose to discuss my health issues with are dealing with the information. That is how e-health literate we are. So summing up, moving forward, and coming back to the rather long question on digital health literacy, collaboration and patient summaries. We need to co-create models, and I think I know something about some of the ingredients that will go into these models, but we for sure need to pay much more attention to digital health literacy so that we all have a responsibility to be data informed and that we are to a much more extent understanding the health information for care, for wellness, for prevention and engagement, for supported self-care, and that we know when it's also a good idea to seek care. We need to think about trust and data integrity in contributions from patients and providers. I just recently came from an international conference where there was a lot of discussion on the patient-generated data, and everyone was so concerned about the integrity and the quality of the patient-generated data. And interestingly enough, they were speaking under the assumption that the data that comes out of a 5-minute encounter is by default valid and accurate. We need to think about data integrity in a new way, and we need to and upgrade what the patients generate themselves. Another aspect of trust is stewardship, and that we can share and complement information, and that it's up to the patient, the citizen, and the person, the citizens chooses to share information with. And we will have, I'm quite sure, very interesting discussions about stewardship and custodianship and access and rights to the data. And then lastly, we need to expand and develop services. We need to co-create a health experience that really put patients at the center and that brings us relevant data. And in that perspective, team collaboration and information that leave the silos is extremely important. FHIR, codes, terminology, standardization are important instruments in that regard. However, more important is a call for expanded competencies. Competencies that makes us fit to work in this new environment, to understand drivers and key skills. We are going to gray. All of us are, whether we like it or not, going to be older. We're going to be, the majority of us are going to be older. It has implications. It has implications for the workforce. It has implications for us as patients. And this, we need to include these dimensions as we are to a larger extent called on and interested in managing our own health. However, in addition to acquiring new competencies, understanding drivers and developing key skills, we need to have some sort of navigation tools and resources in this world of all the different information in different shapes and in different forms. And that could be a digital health compass. And I'm done, Kathy. Thank you for your attention. And I'm extremely glad that I just go these stairs once. So this is your exercise, your wellness.
It's today. It is. I'm scared to death of these steps, these stairs. Thank you for a nice presentation. I think that I'll just let you sit down on that, so we give Alfred a bit more time.
Yeah, thank you.
Okay, now Alfred, you make your way to the stage here. Be careful those stairs.
Yep.
So, our final speaker at this session is Alfrid Stokke. She's director at the Norwegian Directorate of eHealth, our new directorate.
Is it?
Yes, and she's responsible for health terminology and coding. She's a head of a program which, in cooperation with the entire sector, and I like that, the entire sector, that means nursing's included, aims to give Norway a significant boost in this area because we do definitely need it. Alfred is an engineer and has education in leadership and management. She represents Norway in the Nord Class Initiative in WHO, and her title is Cooperation in the Norwegian Health Sector for Better Quality on Quality Clinical Codes and Classifications. Thank you.
Yes. Thank you very much, Katie. And thank you very much, everybody who's still here. I think it's amazing, and it's even been very interesting to hear my co-speakers and all the things that you said about health records. It's very important to us all. So now I will have to drag you down to the building blocks to talk about the building blocks, which is also important for us. So you are all very smart people, because you choose this session here and interested in what we are going to talk about. So so to inspire you a little bit, because it's possible to inspire also with the codes and classification, I just got a little video I would like you to watch first, if we can get it working.
It all starts with the code. It doesn't look like much, just a few letters and numbers. But it's a very important code because it's about a person's health. It's about a pregnancy, a birth, a disease, an injury, an outbreak, a death. It's a code with a long and winding journey. It starts with one person in one hospital or clinic. But it doesn't end there. It joins up with other codes in databases in cities, regions, and countries. It becomes a small but important part of a big picture. It's used to monitor the health of populations large and small, to plan how services are delivered and resources are allocated, to help diagnose diseases and detect changing disease patterns. And where does this code come from? The International Classification of Diseases, or ICD. ICD is a common language used all over the world by doctors, nurses, policymakers, researchers, and many others to classify diseases and conditions so they have the best possible picture of everyone's health. Around the world, more than 100 countries use ICD to record the reasons people die, to monitor the health of their populations, and to help make financing decisions about their health systems. The world needs better health data, and ICD is delivering it. It's another way the World Health Organization is building a healthier world.
Yes. So that was to start. The world needs better health data. And that gets me into my talk to you today. So I would like, if there was like a fairy or a Santa or something in the room right now, then I could make a wish and it would come true. I would wish that all of you just went out after this session and talked to all the stakeholders that you know, and also the people who decide that this area of codes and classification and terminology is important, and we need to have funding for it as well, because it's very important, and it's easy to forget sometimes. So it all starts with a code. I'm going to tell you now a little bit about what we're doing in Director of eHealth with this, together with the sector, and to say a little bit of how far did we come so far, and what are our plans in the different areas. So in this picture, I know you've all seen, especially all the Norwegians that are here many times. It's how it's all put out today for us, and a model of organization structure represents a challenge for national comprehensive e-health solutions. And why I'm showing all this is because for me and for many of you who's sitting here today, we've been working in this sector for a long time, and this is what we have to work with every day. It hasn't changed. There is one change, and that is the little Directorate of eHealth that was established now the 1st of January this year in 2016, that we are going to try to cooperate and to actually drive together the sector for eHealth in Norway. So it's put out like this today. It's a national governance model for eHealth, and we have on the bottom here, it's the Professional and Architectural Advisory Board that will be discussing and giving advice on these issues, also codes, classification, terminology, and so on. Very important issues that is being discussed there. That's been working for a couple of years now, and so has also the National Forum for Prioritization, the NUIT Forum, which is actually making the decisions on the national portfolio. And then this year also we have the National Board of eHealth, which is consists of the management in the most important parts of the sectors, and which is endorsing the national health strategy. So why am I saying this when I'm talking about codes and stuff? Because it's a very important picture to see when we are talking about how can we make these things happen in Norway today. And this is one patient, one citizen that you've been talking about, my co-speakers here, and you all been also seeing earlier on today. And I think, and everybody who's working with codes and classification knows that we need also go into that area and work more hard on that area to make this vision of one patient, one journal actually come true and to be something in the next few years. So I started out a program for classification terminologies in 2015. A little bit before that also, and it's also been originally increased in the need of health sector and the way that we now know that we need to update and standardize data for documentation, decision support, and so on and so forth, that you all also been talking about earlier in this session and also all around the rooms today. And so we found out we needed a program for this, and we have been working on it for a year or so. The main challenges today is when it comes to this particular area is that we have, it's been used for decades, as we saw now, the ICD-10, it's not something new. It's been on for a very long time. But there haven't had the focus that we really wanted to make it better, to make the codes better. It's unmet needs, lack of systematic identification and needs. There's also missing or variable use of established codes today. It's not used well enough. And there's also missing updates and an issue around the version and overlapping codes and so on and so forth. And so that's why we see that there's still need for a significant boost in the area of codes and terminology today. And when you're thinking who really is interested into codes and who really needs it, so we're putting up a model for stakeholders and what kind of stakeholders need the different areas of coding. And we see that I think all of you here, especially, and also developers and provider of ICT solutions, they need them because of standardization of the content. Researchers, everybody who works with statistics and the quality needs also that the codes and classifications are good, well enough, and they can find it at the right place, at the right time, and so on. And also, of course, managers of codes, that's us, and the other ones in the sector is actually managing it, and then health workers who codes and leaders who need it for financial purposes and so on to plan the health work. And finally also, of course, the patient who is the reason for all this. So, so today, this is just to give you a short image on what we're working on. So this is like the 4 areas that we are still as our main areas. It's terminology. Tell you a little bit about that. It's classifications, the traditional classifications, and there's management, development, and education around this, what we are doing compared to that, and IT support. So instead of going through all these and bragging about the results and achievements we had, I think I'll just skip this slide and go to, just to show you that there's actually been results so far also. But we are trying to lift the whole area at the same time. I think it only proves that it's been so many people sitting here now actually interested also means that we have managed to lift the area into the directorate, that it's important that we are driving this in the division that I'm a part of. The division is portfolio steering and standards, and also now classification and codes and terminology. So there's been put an effort to try to lift the whole area. So quality and coding, what are we doing? Very short. There is main challenge in medical coding is that the technical support for correct coding in the HIRs are scarce. It's not well enough done. Coding is time consuming. It's not something that the doctors or the physicians actually drive to do. I mean, it's less is better or all in. We are not talking about should it be the professional coder or should it be actually the doctors who don't do the coding. These are important questions because we see that it's also a bias that comprehension of coding. It's a bias towards funding, and which purpose of the healthcare statistics is less well accepted, and that does something to on how the drive towards coding correctly is. So classification, it's a demanding discipline. It's some of a field that to get into, and also that's why we need good tools in the bottom to give you to code correctly. So we started now, actually, I don't know what that, yeah. So we started now to make a project for developing better coding. You see here also that several studies have been done over the 10 past year, and there is a conclusion that the quality was not good enough, as good as we desired. So poor coding has a consequence, as I said, for funding if it's wrongly coded. It has and financing. It has a consequence for statistics that they become poorly, and also for the registered here for statistics on morbidity and mortality. So as we're speaking now, there's a project management here in this room today, actually, also working to make models for e-learning that we have inherited from the region Health South region, which is also here, I see, to make that better. So we are actually working, it's 8 doctors, 1 nurse, 1 radiologist, and working to make these e-learning models that we really hope will be good and used in this field. So that's very one of the things that we do here. So to terminology, the implementation of SNOMED CT in Norway, what are we doing? It's also being grounded in the vision of one patient, one journal, to make standardized terminology. Not only codes, but also terminology. So in Norway, we haven't until now been a member of the IHG-SDO, and it was a decision actually made this June that we will, there was a long project before that, concluding in a very nice report that I would like you all to look into and to find on our websites in Director of eHealth, which is describing these alternatives and why the road we went to actually make the decision. So the eHealth board this summer made a decision that we will go for the mid alternative here, which means membership with over experienced exploration period of 3 years. And then we will go back and we'll see, was this the right decision or not? And the reason why we are so taking baby steps is because when one of the main findings people who's working very hard with this is that it's a need for collaboration between different frameworks, and like for ICNP, is very important for the nurses. There is many other also terminologies, standards like OpenEHR from HL7 FHIR, also, and so on and so forth, to make a terminology goal for Norway in this. So we needed to take it in baby steps, and we need to do some things to make us, if we did the right decision to go into IHG-SDO. So very basically now it's 4 projects under this terminology hat, and then we have starting to put up a national release center, we call it, which is like a competency that people will be working there actually know about these codes and classification and SNOMED. And there will be a target architecture that I just told you a little bit about. And there is a pilot in dental health, which is a very nice and narrow little area that we could actually try this out in. And also there will be a pilot for value sets and how we can combine terminology to value sets. So maybe there is a couple of you that doesn't know what SNOMED CT is yet, so I'll just put one slide to tell you 2 things about it. So it's the systemized nomenclature of medicine and clinical terms. It's over 300,000 concepts, and there's the description of them between and the relation between them. So it's not only normal terminology, it's actually in an information model that puts the terms together, which is very, very powerful thing to use. use. And every code concept is linked to related concepts. So that's why, in a way, it's not only used. We don't mean to use it only as a code. We also use it to opposed to current codes, which are more like for statistics. This will also be to underline the things that you've been talking about before, you know, in the HIRs. And yeah, so how are we going to implement it? It's a big field, and as I said, it's only a 3 years period of time that we choose to work with this. So, and there is often discussions on implementation strategies we've been asking different countries. We've been to the Netherlands, to Sweden, Denmark, and so on, England, to hear what did you do right and what could we do better. And we found that in this 3 years time, we're going to go for a limit implementation and use SNOMED simple as a code system to see how it works out in some areas. And I mentioned dental health, but it could also be like pre-hospital, we have to take it step by step and actually find the right areas to do it in. So just to give you a small example, this is our dentist, Jørn André, who's made this slide for us, and he's made an example. I'm not a health person myself, but I can see there's his teeth here. So before, he was able to, in his journal, just to put out the description of the teeth. Now, when he's combining the codes from SNOMED CT, you will have the specific, actually, when you see the tooth here, you can actually have the specific on what part of the tooth it is and what kind of illness it is. So you will actually have that structure, vestibular surface of the tooth or something, it says here. So it's a very powerful way of connecting to the journal, how the terms are. Okay. So we also have a project that is very important to us because it's lack of these poor tools actually to support codes and classification and terminology. And it's end of life in Norway for some of these technology. They're also very old. And we need, actually, a very important need to have this project going and to support also the things that we do to put out the codes at the right time, at the right speed, with the version controls and the things that I said was lacking to us. So the new generation of codes are coming. It's going from the traditional codes with one term to one code, as we see in ICD-10, and to ontologies like SNOMED CT was more, and also ICD-11, which is more like that. So we need to support that, and this is pretty much how it looks today. I'm sad to say, but that's the fact. We have actually putting out all these Excel files and distributing them into different databases and web sites, and they will eventually be picked up in the clinical administration systems, and the doctors are struggling, as I said, to put in it everything. So this is a bit more what we would like to have it. And we will be able to put up APIs so that we can make apps, for instance, and there will be more sufficient need for this. So, see my time is running out, so I'll just say a little bit about the ICD-11 and status and the future planning for that, because I know a couple of you guys also has been asking us about what is happening to ICD-11. This is a picture here of two of the doctors working with the clinical codes here in Norway who actually just came back from Tokyo, where there is the WHA conference there right now, the revision conference, to find, and they had a lot of inspiration and told us what is going to happen with the ICD-11. It's increased, the complexity is increased. It's not normal, it's more entities going together, it's combined, it's larger, it's more robust, it's to facilitate into the HSS EPJ, but the HIRs in the hospitals. It's mapped to other terminologies as well, and classifications. And it's a capacity to accommodate a spectrum of user cases, so it's much more advanced than the ICD-10 was. And just keep in mind that America or USFA all just now came from ICD-9 to ICD-10, so it will take time And we need to start right now. And that's why I'm saying it today, because future planning needs to start actually right as we speak. We can't wait until everything is finished to start planning about this. It will be ready for international implementation in 2018, but not in Norwegian language, so it needs also being translated. And we expect, or we will expect, a major decision process for actually making this real for us. And I think it will be needed to get resources over the national budget. And to say the importance of doing it is that WHO strongly appeals to member countries, especially like Norway, who has more means than other countries, to actually join in the standardization process and do something to enhance and test the ICD-11. So we are doing that also. And we are also actually obligated to use it. That is because we are part of the World of Health Organization. So in conclusion, a lot more to do. We are on the case in the Director of eHealth together with the sector, and we want you all to participate. We are putting out reference groups with the sector involved, trying to involve as many as we can to make the codes that actually there today better, but also to jump into these strategies that I'm talking about with the ICD-11, with SNOMED, CT, and so on. It needs to be talked about. Standards, codes, and classification is a treasure to a lot of stakeholders. Also, the people here who's ICT vendors, I would like to see more of them sitting here, because I sometimes can't believe how they didn't realize how much data that's there that they can use sometimes, you know. But we need to be taking this seriously. We all want a better future for the healthcare in Norway and everywhere else, for their sake. It's very important to meet our goals for the vision we have of one patient, one record. So that concludes my talk, and it all starts with a code for me.
Last time up these stairs. Okay.
You manage very well.
Yeah, okay. This, of course, is an interest of a big interest for the Norwegian Nurses Organization, and we really support your work and hope to participate in the future. So I'd like to thank you, and I'd like to thank all of you for participating in this session. There is a coffee break now and demonstrations in the exhibition hall. Thank you. Question there. Okay.
What time is it, David?
At 2:30. 2:30. In English? Okay.
All of you have to go there.
All right. Thank you.
Okay, thank you, Katie.